Hello, we are here today at the National First Responder Conference and we're going to discuss the new guidelines with Brigid Sinnott of the Irish Heart Foundation. Brigid, can you tell us the changes in the new guidelines for first responders?
Certainly can, Susan. So I've put together some slides just for consistency as we go through the new guidelines. So as you can see, our first slide here says that there are no major changes in the guidelines for 2015. But there certainly is an emphasis on systems of care and continuous quality improvement. So I suppose the evidence has sort of said to us that there's no major changes, but we do need to improve how we call people, how we start CPR, and the quality of the CPR itself. The chain of survival, we once upon a time had one chain of survival. Now we have an in-hospital chain of survival and an out-of-hospital chain of survival. And obviously the chain of survival that is relevant here at the Respond conference is the out-of-hospital chain of survival. As you can see, we keep emphasising the first three links in the chain of survival, because if these three links are not intact, survival from out-of-hospital cardiac arrest is minimal. Therefore, we are depending on our dispatchers and our lay people and our bystanders and our responders, community first responders, to ensure that the first three links in the chain of survival are intact. In the pre-hospital, they are encouraging community first responder schemes. And when you see the large group of people that we have here today at the conference, Ireland are doing a great job at the minute. There's also further emphasis on dispatch, and a number of the presentations here today have also involved the importance of dispatch. And here in Ireland now, I know that we're on a new version of the AMPDS system, and the thing is that people are only asked 2 questions now before they can identify a cardiac arrest, which speeds up the whole bystander CPR and the commencement of the compressions. Continued emphasis on quality of CPR. Therefore, if we don't have high quality CPR, chances of survival definitely do decrease. We are now to aim for a chest compression fraction of at least 60%, but for the best outcomes, that's 80%. So I suppose in simple terms, it means that during a cardiac arrest, that you are definitely on the chest doing compressions for at least 60% of the time of the cardiac arrest. And I know anybody that's used to doing CPR knows that that can be actually pretty difficult. By the time you give breaths, by the time AEDs analyse, it all takes time. So we have to make sure during our training and during our cardiac arrests that we ensure that we are on the chest for 60%, at least 60% of the time. The rate of compressions, I suppose they've tied this down a little bit. We always said before that it was at least 100 compressions a minute. Now we are saying it's 100 to 120 compressions per minute. The depth of the compressions remains at 5 centimetres, or for older people, 2 inches. And no greater than 6 centimetres, but don't be emphasising this because the majority of us do not go deep enough when we're doing our compressions. So what else has changed during the compressions? Chest compression feedback devices certainly assist us and haven't been shown to increase survival as yet, but certainly do enhance our CPR. And certainly when we are training, it is well worthwhile having a chest compression feedback device, just so that we can measure the quality of our CPR. Mechanical chest compression devices, there is a place for them, in particular in challenging environments. So I suppose in the back of a moving ambulance would be one of those places, or maybe sometimes at scene, maybe trying to come down the stairs, mechanical devices can certainly be used. For Pediatrics, we are keeping up the compressions airway breathing. They've decided that they're not going to change the sequence, but they are stressing that we must ensure that we also give breaths as well as compressions to paediatrics. The rate of the compressions remains at 100 to 120 for paediatrics and a depth of no more than 6 centimetres. The use of mobile phones during a call, and I'm sure all of the controllers would agree with us on this, we are trying to encourage people to switch on their mobile phones, make the call from their mobile phone, I should say switch on the loudspeaker on their mobile phone and make the call from the mobile phone, putting the mobile phone down beside the victim's head where you can speak with the dispatcher and you can do your CPR as well. This way you have a direct line with the dispatcher and they will certainly give you advice as you go through your CPR. During training, it is good to use the feedback devices. As I've said already, it will give you corrective feedback and it will assess how good your CPR is for you. When you're doing your scenarios, make sure that you are using realistic scenarios. So, 67% of cardiac arrests in Ireland happen in the home. So why not do scenarios in the home, maybe in tight bedrooms, wherever you find victims of cardiac arrest? So keep the scenarios realistic and practice, practice, practice. It's worth noting as well that in the new guidelines they are stating that AED usage is not limited to trained people. So in other words, we need to get the information out there to people that if you have an AED, you can switch it on and you can use it. We do all know though that people who have been trained in CPR and have attended a foreman class are 10 times more likely to respond in an emergency than those that have had no training. Education, we've had lots of presentations here today on team dynamics and pit crew approach, and this is emphasised during both training and during cardiac arrests in the new guidelines. We are still to encourage compression-only CPR to untrained people, and they are leaving the recertification at 2 years, but we are well aware that people need to practice their skills at least every 90 days just to improve the quality of the CPR. For instructors, while testing, we will have new test sheets and it will be important to use your stopwatches and no prompting during skills testing. Candidates really do need to be able to do these skills without any prompting. So what happens next? For AHA instructors, we have some interim materials out currently and we are using those. The BLS for healthcare provider materials are currently available. The PHECC materials are being developed and the Heart Saver materials are being developed also. The lesson maps will remain as practice while watching, and there is an online update for all instructors. For AHA, IHF instructors, you should be completing that online update at the minute. And for all the CFR instructors, you will have an online update through the PHECC website in time as well. So for any further information, feel free to contact the Irish Heart Foundation or the Pre-Hospital Emergency Care Council. Thank you.